Good afternoon, everyone. I'd like to thank the organizer for inviting me to give this talk. My topic today is the future of HIV prevention in Asia. Although it is very difficult to tell the future of anything in the time of pandemic, in my talk, we will try to give you some picture of how we might improve the quality of care for our communities in Asia. This is the outline for my talk. We'll start with implementation of state-of-art diagnostic tools. Testing and making rapid, accurate diagnosis is the paramount of the treatment and the prevention cascades. People tested positive should be given treatment early to achieve undetectable viral load, while people tested negative should be offered biomedical preventions such as PrEP. So how to expedite diagnosis is the key. This is the algorithm recommended by US CDC. After a positive screening test, a specific differentiation immunoassay is needed for confirmation. In most parts of Asia, it's Western blot, which takes days to report. For early infant diagnosis and acute HIV infection, in which the immunoassay results are often indeterminate, a nucleic acid test or NAT will be needed. To expedite confirmation of HIV infection, the initiation of ART or antiretroviral viral therapy, WHO no longer recommended Western blot. Point of care, easy to read diagnostic tools such as Multispot or Genius have become available in our region and should be implemented and replacing Western blot in the future diagnostic algorithm. Nucleic acid test has become more accessible in our region. Scaling up NAT capacity will not only improve diagnosing acute HIV infection and mother-to-child transmission, but with multiplex target platforms with high throughput listed in this table, we can improve the diagnosis and clinical care of other infectious diseases, such as hepatitis B, hepatitis C, and even SARS-CoV-2 as well. In resource-limited countries where these state-of-art diagnostic tools are not yet available, it's still feasible to start ART early with integrase inhibitor-based combination as first-line treatment recommended by WHO. Dolutegravir or bictegravir in either brand name or generic form are very potent, high in genetic barrier, well tolerated, and suitable for most of the treatment-naive patients. Thus, great option for same-day ART. Next, for people tested negative who remain at risk, PrEP will provide additional protection. Now we'll talk about the innovations in the PrEP pipeline. This is the updated R&D pipeline for PrEP. Until March 2021, we have oral PrEP, which can be taken daily or on demand in some populations. Soon we will have vaginal ring, long-acting injectable PrEP, and even long-acting oral PrEP coming up in the future. Tenofovir alafenamide or TAF FTC has become available in some Asian countries as NRTI backbone of the treatment regimen. It has been proved non-inferior to traditional TDF-FTC as daily PrEP among cisgender MSM and transgender women in phase 3 randomized control trial, with significantly less bone and renal side effects. So it will be a good option as daily PrEP for certain populations with comorbidities. To be noted, TAF FTC is only recommended as daily PrEP and hasn't been recommended for cisgender women so far. Event-driven or on-demand PrEP has been recommended among men who have sex with men by WHO since 2019. The dosing is coupled with sexual events and gives a greater flexibility to individuals who doesn't have hepatitis B, less sexually active, who can also plan sex and remember the 2-1-1 dosing schedule. There are questions like how to switch between daily and event-driven PrEP and how to monitor the client's adherence remaining, and we definitely need more local data. An exciting innovation is the pivoring vaginal ring, which can be inserted monthly and provide protection to cisgender women. Phase 3 randomized control trial showed around 30% reduction in HIV incidence, and further open-label extension studies showed 40 to 60% protection rate. It has been recommended by WHO early this year and will receive regulatory approval soon. To be noted again, the pivoring vaginal ring has only been studied in sub-Saharan Africa, and we don't know how it might be accepted by Asian communities. Another exciting innovation is long-acting cabotegravir injection, or KPIA. In combination with long-acting ripivirine, it has been approved as maintenance regimen for virologically suppressed patients in the US. Regarding PrEP, two large-scale phase 3 randomized control trials have been conducted. HPTN-083 among MSN and TG women in America, South Africa, and some countries in Asia. HPTN-084 among cisgender women in sub-Saharan Africa. KPIA 600 milligram were given bi-monthly, and it was compared to daily TDF-FTC as an active control. So both studies were unblinded prematurely because the efficacy of KPIA was found superior to TDF-FTC, with 66% reduction in 083 and 89% reduction in 084 study. While the communities have waited a long time for KPA to be launched, there are still some questions regarding its implementation. First, both KPA and TDF-FTC are very safe and effective. So the individual should choose the preventive method based on their needs and preference rather than clinical efficacy. Second, although long-acting injectable might solve some adherence issue, clients still need to take both KPA regularly. And showing the picture on the right side of the slide, 16 HIV infections were observed in the KPA arm in 083 study. 5 persons, as shown in group B, were lost to follow-up and later became infected. Well, in addition, there are 4 persons, as in group D, have breakthrough infections in participants adherent to KPA shots. Diagnosis of HIV infection in such circumstances has been difficult and needs additional testing strategies or methodology. Last but not least, how people can get KPA and how much people need to pay for KPA is still crucial determinant for its further implementation. Two other novel agents are at early phases of development. One is called Islatravir. It is the first NRTTI or nucleoside reverse transcriptase translocation inhibitor had dual mechanisms such as delay chain termination and inhibiting translocation. It has been developed as treatment because Islatravir is very potent, well tolerated, has favorable safety and resistance profile, and a long half-life. As PrEP, Islatravir was developed in 2 forms. It's a monthly oral tablet and a subdermal implant, as shown on the right lower side of the slide, which might be inserted once a year according to the PK projection in the phase 1 study. Another novel agent is Lenacapavir, also the first selective capsid inhibitor, interfering with the capsid disassembly and assembly in multiple steps of the viral replication. Like Islatravir, it is also very potent, well tolerated, has favorable safety profile and a long half-life. As PrEP, it has developed as subcutaneous injection given every 6 months, according to the PK simulation in the phase 1 study. Phase 2 studies will begin later this year. Here are the projected time for these novel agents to be launched in the market. While KPA might be available starting 2022, oral Islatravir and the Lenacapavir injection might need to wait until 2024. Finally, despite all the amazing state-of-art diagnostic tools and innovations we have, all implementation projects and policies need to be flexible and adaptive in the face of emerging health problems. First is chemsex, or sexualized drug use. It's not an uncommon phenomenon among MSM in Asia. The prevalence in our region range from 5 to 30%, depending on how and whom you sampled. It also has become an emerging health issue around the world. It's become an emerging health issue because one of the most frequently used substances during chemsex, crystal methamphetamine, was associated with riskier condomless sex, shown by the Astra study in UK. Our Australian and the Taiwanese colleagues from COMET study also found that slamming or intravenous injection of crystal methamphetamine was not only associated with higher risk behaviors, but HCV infection as well. In light of increasing number of individuals having chemsex, integrated service providing PrEP, STD screening and treatment, and mental health and substance intervention should be planned ahead. Finally, COVID-19. It has changed the way people live, how doctors practice medicine, and how public health sectors implement HIV prevention. During lockdown, it has been shown that people might not decrease the use of PrEP, but will receive HIV and other STD screening less frequently. Therefore, home care systems and telemedicine have been experimented in the US. With a slow vaccination rate in most countries in our region, we might think about delivering PrEP and other preventive services like Foodpanda and the Uber Eats. So the take-home message for today, using rapid point-of-care confirmatory assays can expedite ART initiation. Also, scaling up NAT capacity can improve early infant diagnosis, identify acute HIV infection, and also diagnosing other infectious diseases such as COVID-19. Novel PrEP agents and strategies can provide more choices to our clients, although implementation and access in the future is still very critical. And all future preventive measures should be designed flexible and easily adaptive to emerging public health issues such as chemsex and COVID-19. Thank you.